Good afternoon, doctors. Today is World COPD Day, 16th of the November 2016. The theme of the COPD Day this year is Breathe in Knowledge. Knowledge to the patient about their disease and knowledge to doctors about how to manage COPD. We briefly look at the gold guidelines on how to treat COPD. You all very well know what is a COPD. It's a common preventable and treatable disease with persistent airflow limitation, which is progressive and because of the enhanced chronic inflammatory response in the airways. Exacerbations and comorbidities are common to COPD. We all know smoking is a common risk factor, but nowadays indoor and outdoor air pollution is becoming an important risk factor in developing COPD even in those who do not smoke. Considering what happened in New Delhi few days back can impress upon your mind what can lead to COPD. So any patient who has a shortness of breath, chronic cough and sputum who has been exposed to these risk factors should undergo spirometry, which is the requirement to diagnose COPD. And after you have diagnosed COPD, you need to assess symptoms. There are 3 questionnaires based on which you can categorize patient severity. The commonest one is the spirometry indices, FEV1 to FVC ratio. So those patients who have less than 0.7 as a ratio can be categorized depending on the severity into mild, moderate, severe and very severe COPD. Then we go on assessing the symptoms of the patient. If the COPD assessment test is less than 10 or more than 10, you can categorize patient into either A and C or B and D. To further categorize them into these 4 groups, you can include symptoms of breathlessness as per the modified MRC criteria. Further, you add the risk of exacerbation, whether the patient had how many exacerbations in previous year. He can be further classified into these 4 groups. The other parameter that you add is the hospital admission history. After this, you have to assess what other COPD comorbidities are there in the patient, whether the patient has any cardiovascular disease, osteoporosis, diabetes, lung cancer or bronchiectasis. Treatment of these comorbidities is equally important. Most doctors confuse a lot between COPD and asthma. The important differentiation is that the COPD usually starts after the midlife, and you can have history of asthma is right from the early days of life. Important thing is the symptoms in COPD are slowly progressive, but this is not seen in asthma. The symptom may vary from day, from the season and year to year. Also in asthma there will be other features of allergy like rhinitis, eczema, or there could be a family history of asthma. And most important in COPD there will be the history of exposure to pollution, or there will be history of heavy smoking. Other than spirometry, what all investigations you do? It's chest x-ray, then arterial blood gas, and in rare cases you can think about doing alpha-1 antitrypsin deficiency. So how do we proceed in treatment of COPD? Smoking cessation is the first thing that you impress upon patient's mind, that this is the single most intervention which will decrease the symptoms by half. So before you proceed with medicines or inhalers, please give time for smoking cessation. Then of course you have long list of medicines starting from simple bronchodilators like salbutamol, ipratropium, tiotropium, salmeterol, or a combination of a bronchodilator and a steroid. A word of caution in treatment of COPD is that systemic steroids should be avoided. One of the important drugs often forgotten in severe stages is the phosphodiesterase 4 inhibitor, roflumilast, which decreases exacerbation uh, in those patients who are treated with oral steroids. Our good old friend theophylline or daryphylline is there, but it is a modest bronchodilator. It has more side effects than benefits, but you can still use. Please don't use antibiotics very often. If there is a clear bacterial infection, please go ahead with it. But not to forget is vaccination. So those patients of COPD who are 65 years and more, definitely they need pneumococcal and influenza vaccine. And also in patients who have very severe COPD, FEV1 less than 40, they can be offered these vaccines. Rehabilitation is an important aspect of COPD. A regular pulmonary rehabilitation program, 6 weeks, which is followed at home, can do wonders in COPD patients. Some unfortunate patients require oxygen therapy at home, what we call long-term oxygen therapy, or they might also require some sort of ventilatory support at home called non-invasive ventilation. So how do we proceed as per the severity stage? So if there is a stage A, you just simply give bronchodilators. If the stage C or D is there, you have to add long-term bronchodilators and anticholinergics along with inhaled steroids. Just a small recap. Prevention of COPD is most important and should be given high priority. Spirometry is the most important test to diagnose COPD, and not to forget pulmonary rehabilitation along with therapeutic drugs. Thank you very much.